Thank you very much, Francesco. Thank you very much once again for being here with us. We had a very tight schedule, an amazing day around the aortic dissection. So I have to talk about the treatment of tibial dissection treated under deep hypothermic circulatory arrest. So one of the technical aspects, we have to cannulate the femoral vessels if possible. Sometimes it's not possible, and we can cannulate either the renal vein or the abdominal aorta, or I don't know. Depends on the morphological approach. You have to have an Y arterial line, just like an accessory line, just to rewarm the upper part of the body. You have to use complete cardiopulmonary bypass instead of left shunt, as we have already seen before. And it's really mandatory to have a left ventricular venting just to avoid the very massive amount of blood in the heart while it's not working. The deeper hypothermia, that means that we are under 20 degrees, sometimes 20, sometimes 18 degrees. I must admit that sometimes if you have just only one anastomosis to perform, you can go with an arrest with 25 degrees, and then you can work for 20 minutes without any problem. One of the main things is to avoid dangerous maneuvers during calling. I mean that you can have something like an injury of the arterial pulmonary artery while you are working before the temperature is low enough, and this is very dangerous because you have to make put your finger on the wound and just wait the temperature to cool down enough before stopping the pump. So. The technical aspect, once the temperature is low enough, you have to interrupt the cardiopulmonary bypass, and the patient is placed in head-down position, is exsanguinated by the venous drainage, and then you have to clamp the distal aorta, just like this, and this avoids a large amount of blood coming to the operative field. And of course, you don't have to clamp proximally like this. So you can open the aorta, you can inspect the flaps, and just to localize the entry-tear, which is most of the times located just around the birth of the left subclavian. Then you have to control the back bleeding from the intercostal. It's very mandatory to do this before putting the graft, because once the graft is anastomosed, it's sometimes very difficult to go at the backside, and you have a bleeding coming from there. It's sometimes difficult to control. And then you make the proximal reinforcement of the anastomosis, and then the proximal anastomosis without any problem. Once the proximal anastomosis is completed, you can restore the cardiopulmonary bypass by the accessory line, just as depicted here, and this allows the rewarming of the upper part of the body. And then you can take benefit of the hypothermia for the optimal protection of spinal cord and visceral protection. I mean that in our institution we don't ever do monitoring of potentials, and we don't ever perfuse the kidneys with custodials or something like this. Then you check for proximal suture leaks that can happen. It has to be fixed at that time. And you put the patient in a position. You can open the distal aorta and rewarm the body, the upper part of the body. And then you make the distal anastomosis, either on the thoracic, if it's the case, or on the thoracoabdominal. If it's the case, you have to reimplant all the critical arteries to the spinal cord or to the visceral, if necessary. And then once all the anastomosis are completed, you can rewarm the patients both by the upper accessory line and by the lower accessory line. You have to gain 1 degree each 3 minutes. That can be very long if you have very fat patients. And of course, we don't like very fat patients for this kind of technique. The cardiac defibrillation may be spontaneous, or you can help it by a defibrillator, and then the pump is wound and the heparin is reversed. So our current indications, of course, we use this indication in case of huge proximal aneurysms with no access to the aortic arch like this. And of course, when the aortic arch is involved by the dissection itself, we can go by a left approach just through the aortic arch, just at the level of the left carotid artery and even at the level of the innominate artery. Of course, then you have to have a decrease in temperature as lowest as 16 or 18 degrees. When you have a spontaneous rupture, we use the technique also, or when you have an intraoperative aortic or pulmonary aortic rupture, and then you have to cannulate first the femoral in case of spontaneous rupture, and then lower the temperature, and once the pump is off, you can open the chest just like this. In case when we want to avoid proximal clamping, just to avoid some retrograde dissections, as I saw you had already one also, and patients always die from this. And of course, it's when you have a Marfan syndrome, it's mandatory for us. Visceral and spinal cord protection, we already talked about this. Or previous surgery and reduced surgery, we use hypothermic bypass, hypothermic arrest also. In the literature, there are a small number of series with 100% of dissections, but with this small number of series, we can draw some conclusions, and other series with more than 50% of patients operated under DHCA. And then we can see that spinal cord ischemia is around 6 to 9% here, and there it's very low numbers of spinal cord ischemia or death. We can see that number of deaths in the Coselli series is higher because there are mainly emergency cases in this series only. So it's a routine technique of open repair. It allows a bloodless operative field. It avoids proximal aortic control and clamping. It allows, according to a spinal cord and visceral protection, which could be optimal, but on the contrary, there are drawbacks. Coagulation disorders, of course there are, and respiratory complications, mainly because sometimes we have a huge hemorrhage coming from the lung. It's terrible for the patients. Thank you very much.